Greetings from SMF. My name is Dr. Amit Kumar Sharma. I'm a full-time consultant at sundarammedicalfundation, and I'm a general trauma surgeon. I do trauma surgery as well as arthroplasty and arthroscopy. I've been at SMF for more than 10 years now, and we pride ourselves at managing all kinds of bony injuries, all kinds of joint disorders, and we also do joint replacements as well as arthroscopic treatment.
What are the symptoms with which a patient comes with arthritis, and what would be your recommendation for these patients with arthritis of the knee, which is a common problem?
So arthritis is basically one of the commonest symptoms or diseases we see in the OPD, and the hallmark symptom of arthritis is pain. So the largest majority of patients will come with pain, and usually starts with one joint, and then there are some patients who may have involvement of multiple joints also, but they often present with pain in one joint. Arthritis is of different kinds, and the symptoms usually vary with the kind of arthritis. Younger patients sometimes come with inflammatory arthritis, like what we commonly know as rheumatoid arthritis, or sometimes there may be arthritis like uric acid related arthritis. In older patients, we see arthritis related to wear and tear, which is commonly called osteoarthritis, and this usually happens when the joint is worn out from decades of usage. And the treatment basically depends upon first identifying the cause of the arthritis and then addressing it. So while inflammatory arthritis are treated very well with medication, the arthritis that basically are because of wear and tear or degenerative arthritis, as we call it, are often treated with physiotherapy and a different kind of modalities. Sometimes some of them, being very bad, are often require surgery also to treat.
What is the role of intraarticular injections in arthritis? And how would you? What would be your recommendations, suggestions to the patient? At what stage would you recommend?
So intraarticular injections are usually used as a second or a third line of treatment. The initial treatment for most arthritis is medical, non-invasive, which means we are not poking the patient or doing anything invasive to him. Sometimes some of these patients do not respond to medical therapy, and then we have to resort to more invasive treatment like joint injection. These are somewhere in between medical and final surgical therapy, and they often help either buy time before the definitive treatment, or they help in symptomatic relief. Injections can be of different types. There are injections which are so-called lubricants, which can be given for wear and tear or degenerative arthritis. Sometimes in inflammatory arthritis, where there is a lot of inflammation locally in the joint, we can give injections which contain small doses of steroids, which have the advantage of not affecting the entire body, but having a high concentration in the joint. They work very well in these kind of arthritis. There are also some biological injections like stem cells or platelet-rich plasma, which are under investigation, and a large majority of patients do seem to find them quite helpful in some kind of arthritis. It depends upon what arthritis you have.
What is the role of surgery in a degenerative parent arthritis? When can the patients be subjected or patient for surgery? How would you select the patient? So when would you say that is the right time to intervene surgically or to wait?
So degenerative arthritis, commonly I think you are referring to osteoarthritis, which happens with wear and tear of the joint over the ages. We sort of compare, you can imagine a tire on the car. With time, with overuse, the tire gradually wears out, and at a certain point of time, it's very difficult to run the car effectively without retreading the tire or replacing it. So the joint replacement aims to do the same thing. It is technically resurfacing the joint so that it is no longer painful. This is kept as a last modality of treatment. We start with non-surgical treatment as much as possible, from medication to physiotherapy to exercises, then move on to lesser invasive modalities like joint injections, and finally, when all of these options have been exhausted, but the patient continues to have symptoms which are affecting the patient's day-to-day living, or which are affecting what we call the quality of life of the patient. For example, a patient who thinks twice before getting up from bed and going to the toilet, or somebody who is not able to go out to the temple to pray, or even getting in and out of the car is very painful, and you've exhausted all your options, non-operative options. In that case, we offer surgery to these patients, and the large majority of them get back to a normal day-to-day life very quickly, within about 2 to 3 months, and they are very happy because the efficacy of this surgery and the longevity of this surgery is a few decades. So for most of at the age that we do these surgeries, most patients, this lasts lifelong, and it's a very positive modifier of their lifestyle. Minister.
Is there a role for braces and orthoses in arthritis?
Definitely. There is in the non-operative spectrum, braces and orthoses do play a very important role. Very often, joint pains can happen because of misalignment, and some of these alignment, if they are not fixed, if they are correctable, then these can be corrected and maintained by using a good brace. Although not all the arthritis can be treated like this, there are a certain subset of patients which can be selected, and if properly managed with braces, they can actually go through years without requiring surgery just with the management of braces.
Coming to trauma, what are the common everyday injuries that you encounter in the ER and OP?
So, some of the commonest injuries that we see, again, it depends on which age group we see in. Children often have a tendency to fall on their outstretched hand, and they often sustain elbow injuries very, very commonly. These can be something as simple as a small nursemaid's elbow, which can be reduced and splinted in the emergency itself, and the child can go home. Sometimes there can be elbow fractures, which require either a plaster or a small surgical procedure where we reduce it under anesthesia. In the active population, we often see ankle injuries being the commonest. One of the commonest injuries is an ankle sprain, which I think everybody in their life at some point of time has faced. These can be simple injuries with just a ligament strain, or some of them can even progress on to fractures, as we see in elderly patients who have a twisting injury. And in more elderly, we see the commonest injuries I have seen in my practice is either a hip fracture or a spine fracture. Again, the treatment will depend upon the grade of the injury, the severity of the injury, and the functional requirement of the patient.
Can you elaborate on RICE therapy for injuries involving the upper and lower limbs?
RICE basically stands for, it's an acronym for rest, ice packs, compression, and elevation. So the first part is rest, where you basically rest the limb or the injured joint or the ankle. Like for example, let us take ankle injuries. When you have an ankle injury, you rest the ankle, you don't walk on it. So you either sit or you lie down without putting weight on the ankle. The second one is ice packs. Ice pack application will reduce swelling in any joint. Any acute injury, first thing you apply is ice pack. You do not use hot compressors. Third thing is compression. Compression means a gentle compression with something like a crepe bandage, where you don't tighten the bandage too much, not enough to cut off the blood supply, but just enough to prevent the swelling from increasing. And elevation, of course, is using gravity to elevate the injured limb above the level of the heart, so it allows for venous drainage and to prevent any swelling accumulating. And once you do this, then you seek the medical care after that.
What is your message to the public on how to handle a patient with polytrauma before bringing the patient to the ER?
So polytrauma basically means in multiple injuries, multiple significant injuries. These may include not just fractures but also injuries to the chest wall, open injuries where large parts of the skin and muscle are lost, and there may be a lot of blood loss. These may also be complicated with head injuries and spine injuries. So when faced with polytrauma, the first thing is ABC, which is the basic airway breathing circulation, which most basic life support courses will teach you. I am not going into the details of this, but first is to ensure that save the patient's life. So the airway should be clear, the patient should be able to breathe properly, and circulation should be maintained. Once these are done, then as far as the orthopedic part of it is concerned, first thing is you staunch any bleeding. So if there is any active bleeding, put pressure on that. The second thing is, if there are any very obvious bony injuries like a awkwardly lying limb, or if there is any creaking or crepitus when you are moving a limb where you think there may be a fracture, you splint it with using any board or any rigid structure and a bandage available. And once you stabilize it, you make sure you don't move the patient too much, put the patient on a stretcher, and as soon as possible take him to the nearest hospital. This is ideally done as a team, where you depute different responsibilities to different people. One person should be responsible about calling the emergency services and coordinating with them how to get to the site of accident. Second person should be coordinating with should be taking care of the patient itself, and third person should be trying to reach the patient's relatives or the police station or whoever can take care of the patient at the earliest. Thank you.